Hello everyone, and welcome to Tips and Tricks on Maxillary Anesthesia. This is Alan Boudens, and my plan this evening is to take about 45 minutes to go through the presentation, and then I'll answer questions that are posted after that. So let's go ahead and get into the program here. So for maxillary anesthesia, certainly we have both infiltrations and blocks that work pretty well. Infiltrations, we can pretty much give these anywhere throughout the maxilla and we'll have a pretty good result. And there's very good evidence that using articaine, commercially known as Septicaine or Septinest, are two of the biggest commercial names, we know that articaine really does help to make these infiltration injections work even better. And there's good evidence that it also tends to make the anesthesia more profound and a little better duration as well. And lots of times with articaine, we can give a buccal infiltration and we'll have very good anesthesia on the palatal side as well as on the buccal side, just with that simple infiltration injection. And there's some very good literature, some studies backing up this information here. This meta-analysis published in the Journal of the American Dental Association back in 2011 looked very critically at all the studies that were out there and found very good evidence of articaine's superiority over lidocaine when used as an infiltration injection. But I think it's equally important, this second statement from that paper was that the evidence was weak for any significant difference between using lidocaine or articaine for a block injection. There really was no advantage to using Septicaine in this block situation. And another paper, this is more recent from the Journal of Endodontics, articaine 4 times more effective with greater duration than lidocaine as an infiltration injection when used on teeth that are diagnosed with irreversible pulpitis. And certainly if it's going to work for a hot tooth, for a tooth with irreversible pulpitis, it should work very well for a normal tooth that we're doing simple restorative procedures on. So some very good evidence out there of superiority of articaine when used for an infiltration. So my basic armamentarium of anesthetic agents, as you'll see here, 2% lidocaine with 1 to 100,000 epinephrine is still my primary workhorse. I use this for most of my block injections. I use a little bit of mepivacaine plain when I want to avoid a vasoconstrictor, or if I'm doing a very short procedure, usually a simple occlusal filling on a single tooth, or I want to get a couple of teeth numb, and I'll inject this in between the two teeth, approximating the apices, to get the teeth on either side numbed up. I can get in and get into some deep pockets, do some curetting, that type of thing. And then articaine is my primary go-to anesthetic for infiltrations, and I also do use this sometimes for those difficult to get numb patients. This may be patients with a history of drug abuse or current drug use for that matter, or patients, sometimes I find patients who are heavy coffee drinkers or heavy smokers. Those patients can be rather difficult to get numb sometimes too. So I find articaine very useful in those patients there. And I like to use the 1 to 200,000 epinephrine formulation because my anesthetic is just as profound. Duration maybe a handful of minutes less than the 1 to 100,000 epinephrine formulation, but it's also a little safer if I should accidentally get a little bit into a blood vessel. And then finally I use some bupivacaine, the long-acting anesthetic Marcaine or Vivacaine, in some cases where I want to add that on to my basic lidocaine to get a longer duration to do a major restorative case that might take me 3-4 hours, something like that. I can add this on in combination with my lidocaine and get very good duration of anesthesia with very little anesthetic use. And then I do like to use some buffering agent to get faster onset, and I like using some of the Auraverse anesthetic reversal agent to reverse the effects of the vasoconstrictor and allow the patient to return to normal sensation, normal function sooner after the dental appointment is completed. But we'll talk about that a little more later on. Okay, so infiltration versus block injections. Certainly there are a number of advantages of infiltrations. Very rapid onset, very simple, easy to do. Pretty safe because where we're injecting up into the vestibule and approximating the apex of the teeth, we don't have major blood vessels in those areas, so not much risk of intravascular injection. Still want to play it safe though. And obviously we can get better hemostasis if we're using an anesthetic agent with a vasoconstrictor. But disadvantages, if we're working on a quadrant of teeth, multiple teeth, then we'd have to use multiple injections to get that entire quadrant. And I haven't met a patient yet who has begged me to give them more injections. It's always the fewer I can give to get the anesthetic effect that I need and the number of teeth that I need anesthetized, patients are happy with the fewer number. And then certainly an infiltration injection does not give us as good a duration as do our block injections. So here's a graph here. You'll notice the time scale on the left-hand side, 70 minutes up at the top. In the center we have our big four anesthetics, lidocaine, mepivacaine, prilocaine, and articaine. And with these four, we can pretty reliably get about an hour of pulpal anesthesia with an infiltration injection. Now that's going to vary a little bit depending on the individual person. It's going to be a bit of a bell-shaped curve. Some people a little longer, some people a little shorter duration, but on average about an hour. Now I want you to notice over here on the far right side the bupivacaine, the long-acting anesthetic. When administered as an infiltration, this is usually inferior to our other anesthetic agents. It does not give us as good a duration when it's delivered as an infiltration. And over on the far left side, we have plain lidocaine, which, by the way, is not available in North America as a anesthetic agent within a dental cartridge. And I'm honestly not sure if it's available anywhere in the world in a dental cartridge. And right next to it, we've got in the blue there the prilocaine plain, which also, as an infiltration, is very poor pulpal duration, about 5 to 10 minutes for the plain anesthetics there. But then just to the right of those, we see mepivacaine, and the duration of that as an infiltration is about a half an hour of pulpal anesthesia. And that's why I like to use that for the short duration invasive type of procedures. Okay, on the next slide here, this graph on the right-hand side, notice the time scale over here is quite a bit different. So here's our big four in the center again, lidocaine, mepivacaine, prilocaine, and articaine. And delivered as a block, these anesthetics are good for about an hour and a half to 2 hours, somewhere in between 90 to 120 minutes. So we've about doubled our duration of pulpal anesthesia. And then also over on the far right, notice that delivered as a block, our bupivacaine, our marcaine, vivacaine, long-acting anesthetic is now giving us several hours of potential pulpal anesthesia when it's delivered as a block. And also if we look over on the left side, the blue column here, the prilocaine plain, if we deliver prilocaine plain as a block injection, we can greatly increase its duration of pulpal anesthesia, get that up to a good 45, maybe 50 minutes, maybe even an hour of pulpal duration if we give it as a block rather than as an infiltration. So what we're seeing here is that in terms of duration, we have a number of factors that affect the duration just based upon the anesthetic agent itself. And I'd say that probably lipid solubility and protein binding are two of the biggest factors there. And that's really the same thing that we see for onset as well. The only difference in the characteristics of the anesthetic agent is how well it diffuses through to the nerve for onset and how rapidly it diffuses away from the nerve for duration. And these are highly related, again, to the lipid solubility and the protein binding. But also for duration and for onset, a little bit dependent upon the technique, as I just showed you with those graphs there, whether we're using a block or an infiltration type of injection. But one more thing for duration is whether or not we have vasoconstrictor in the anesthetic formulation. Now, it doesn't really matter too much what the concentration of the vasoconstrictor is. For example, in North America, we can get lidocaine with 1 to 50,000 or 1 to 100,000 epinephrine. The duration of anesthesia between those two formulations is not very many minutes. We're talking 5, maybe 10 minutes at the most difference in pulpal anesthesia. But certainly, if we get a little bit of that into the bloodstream, it's going to be a much more measurable difference between the effect it's going to have on the patient. So I prefer to use the lower concentration with lidocaine 1 to 100,000, and the same thing with articaine, septicaine. I prefer to use the 1 to 200,000 for anesthesia because it's a little safer. But if I'm doing surgery, if I'm going to get a fair amount of bleeding, I'm going to do root planing where I know the patient's going to bleed a good bit, I'm probably better off to now switch to using infiltrations with lidocaine 1 to 50,000 because that will definitely give me better bleeding control. And in a surgical situation, that's extremely important to me. So it all depends on what I'm doing as to what formulation is really best. But for most restorative dentistry, I like to go with the lower concentration of vasoconstrictor. All right, so let's talk a little bit about techniques here. For the maxilla, we've got a bunch of different block techniques that we can use. I'm not going to have the time this evening to go through all of these real thoroughly, so I want to kind of concentrate first off on getting the anterior and middle superior alveolar nerves, getting these nerves that we can see over here on the upper diagram. These are nerves coming down to the incisor teeth, the anterior superior alveolar nerve, and to the bicuspid teeth with the middle superior alveolar nerve. So to get these anterior teeth to do restorative work, and we'll talk about a couple different techniques for doing this, and then I want to talk about one of my all-time favorite techniques, and that's a very efficient method of getting a complete maxillary division nerve block. Okay, so starting out here talking about our anterior and middle superior alveolar nerves, the traditional technique that's been taught for many decades is the infraorbital approach to get these anterior teeth. With this approach, we need to figure out where the infraorbital foramen is. And this is just a little bit below the eye, but to give you a little more hands-on way of assuring yourself where this is, what I like to do is simply take my finger and feel the inferior rim of the orbit. And I feel for the lowest spot of the orbit. That's what I'm doing in this upper picture. And that low spot is usually a little more towards the base of the nose rather than truly right in the middle below the eye. So I feel for that low spot in the rim and then drop my finger down 10 millimeters or 1 centimeter, and my finger will be right over the infraorbital foramen. I can usually feel a little dent there, and if you press firmly enough, you might even get a little bit of nerve tingling, a little bit of Tinel's sign. So once I find that spot, I leave my finger there over the infraorbital foramen, and now I'm going to take my thumb and I'm going to hook that up into the vestibule and get the tip of my thumb all the way up to the very, very top of the vestibule. And that means that then my depth of penetration out of the vestibule is only going to be the distance between those two fingertips. I'm going to go parallel with the anterior slope of the maxilla. I'm going to insert the needle. The depth of penetration is going to vary a little bit depending on the height of the individual's vestibule and the height of each person's maxilla itself. So it's going to vary a little bit. I can use a short needle on this, and I'm going to drop about a half to maybe a third of a cartridge of anesthetic here, using lidocaine generally. And I can do this quite comfortably for the patient. Now there is a little bit of difference in comfort level depending on the technique. So the next slide here, I'm just illustrating the technique on skulls, and here we see the traditional technique that was coming in over the anterior teeth. You're coming up this anterior slope of the bone and approximating the apex here. Now, in this anterior area, it's very sensitive, so patients usually feel that. So what I prefer to do is to take an approach that's more over the bicuspids. It's a little straighter up. It's a little more awkward because I've got to get the corner of the patient's mouth retracted out of the way. But I find this gives me a more direct approach and a more comfortable approach for the patient. Now, also noted here, I made the note that you don't need to get the needle tip into the foramen itself. I've got my finger placed over this foramen, and so I can feel the needle when it comes up into the tissue. And I just stop once I feel the needle underneath my finger. And the reason I say this is because I know many people are afraid that they're going to go right into that foramen and not feel anything, and oops, they're going to go up into the orbit, or perhaps they're going to miss and they're going to go over the inferior rim of the orbit here and oops, into the eyeball. No, that's not going to happen. By keeping my finger over the foramen here, again, I can feel the needle when it comes in underneath the tissue there. Once I feel it, I stop, I drop my bolus of anesthetic, take the needle out, and then I massage the anesthetic and work it into the foramen. And I give this injection with the patient lying back, and I leave the patient lying back, rub the anesthetic in, and it will flow right into the foramen and right up the canal and anesthetize the nerves for me. So that works very nicely and very safely. Now, one thing about this infraorbital approach is that in a fair number of patients, 28% here, almost a third of patients, they actually don't have this middle superior alveolar nerve. It doesn't exist. And in those situations, the innervation to the bicuspid teeth usually comes from the posterior superior alveolar nerve. You can kind of see on this lower diagram, what we have is really a plexus of nerves created by these alveolar nerves, and most of what's coming to the bicuspid in the situation where the middle is missing is coming from the posterior superior alveolar. So in that situation, if we use the infraorbital approach, we won't get the bicuspid teeth anesthetized. It won't work. We'll only get the anteriors. And one more thing is you'll also notice that this injection technique does not get the palate in either case. So we would have to give a separate palatal injection or two to get the palatal tissue anesthetized and to block out potential accessory innervation that could be coming to the pulps of those maxillary teeth from the palate side. So there is another alternative technique, and this is called the palatal approach to the anterior and middle superior alveolar nerve block. This is a technique that was made popular more recently with the introduction of the wand computer-controlled anesthetic delivery device, but it's a technique that's actually been around for quite a long time, since I think the first paper I found on it was in the 1920s. But what we're going to do is we're going to take the midline of the hard palate, the mid-palatal raphe, and we're going to drop a line perpendicular to that will come out and bisect the two bicuspids. Or if the orthodontist has removed a bicuspid, we can just bisect the one remaining bicuspid. We're going to come halfway out along that perpendicular, halfway between the midline raphe and the free gingival margin of the bicuspids, and that's where we want to go ahead and inject our anesthetic solution. Another way of thinking of this is that we're going to inject at kind of the junction between the more horizontal, the more flat, hard palate, and the more vertical alveolar process. So this is roughly approximating the apices of these bicuspid teeth on the palatal side. It may be a little bit above the apices of those teeth. Our depth of penetration is going to be minimal because we're injecting onto the palate. I use a short needle for this, and I slowly tease in up to maybe 1/4 of a cartridge of articaine. I like using articaine septicaine for this because of the better perfusion of this through the tissue. So I give this, as noted here under the comfort level, I give this very slowly, just easing that anesthetic in to keep this comfortable for the patient. Now, why do I really like this technique versus the infraorbital approach? Well, a couple of things here. Number one, with this single palatal injection, I get buccal soft tissue, I get palatal soft tissue as well as getting the pulps of the anterior 3 teeth and of the 2 bicuspids. Also, is that I don't get the face. I don't get the mid-face, the side of the nose, the lower eyelid, or the upper lip anesthetized. So the patient can maintain a normal smile line and so forth. That's always nice, both for my work, if I'm doing aesthetic work, I want to see the smile line, or for the patient when they need to get back to work or whatever type of thing like that. After the procedure, they have a more normal appearance and function. I get more reliable pulpal anesthesia of these bicuspids. So even in that almost a third of the patients who are missing that middle superior alveolar nerve, I still get pulpal anesthesia of the bicuspids. So that's a big plus there of this technique versus the infraorbital approach. But, like every other injection, there's always a but in there. There are always disadvantages as well. The duration of this injection is not quite as long as what you would get with an infraorbital approach, because this is kind of a hybrid in between an infiltration injection and a true block injection. So the duration, not quite as good as a true block, but not bad. But most people will go, oh my goodness, that's a palatal injection. Ooh, I can't give palatal injections. Patients hate those. Well, you know what? You need to learn to give comfortable palatal injections. That's a huge practice builder. If you can give a comfortable palatal injection, your patients are going to really love you. So it's something you want to learn how to do rather than just keep trying to avoid it. Learn how to do it. So here are the things I do to make palatal injections quite comfortable for patients. Number one, I'm a big believer in topical anesthetic. I know that may be controversial with some people. Yes, the depth of penetration is minimal. It will not, for example, if you're doing a deep block injection, it will not anesthetize the entire needle pathway into all the tissue. But that's not the point. It's to get the surface mucosa numbed up so that they don't feel that needle stick quite as much. So I use that as a pre-injection for all of my techniques. And for the palate especially, I like to use a little pressure distraction, or I might use a little vibrator instrument like the Dental Vibe or the Vibroject, one of those type of instruments that creates an ultrasonic vibration that's both a distractor but also helps to give us a more efficient and more profound anesthesia. So I use the distraction techniques there. I give these injections very, very slowly, just teasing the anesthetic in. You know, for this palatal anterior and middle superior alveolar nerve injection, I will take probably about a minute to give that quarter of a cartridge of anesthetic. Now, in some patients who are particularly fearful or particularly sensitive, I will give a buccal infiltration first with articaine. And lots of times that'll help to numb up the palatal tissue. If I wait about 3 minutes or so, that will get the palatal tissue somewhat anesthetized, and that makes it a little easier to give the palatal injection as well. But I think the most important thing really is explaining to the patient everything that I do. And this is where I feel that regardless of your opinion about topical working physiologically, I think topical works extremely well psychologically. Because I explain to the patient, I'm going to put some topical anesthetic on here just to numb up the surface of the tissue so you won't feel the stick of the needle quite as much. I stress quite as much. I don't say they won't feel it. I just say they won't feel it quite as much. And then I tell them that I'm going to create a little pressure here, a little vibration, so they don't feel the needle as much. I tell them I'm going to give the injection really slowly, so they don't feel it as much. And when you do that, the psychology, if they trust you, the psychology of explaining all this makes the patient more comfortable, and it makes the injection more comfortable. So, you know, I strongly urge you, don't avoid palatal injections, learn how to give them comfortably, because It'll really help build your practice and make you a lot happier, giving a more versatile menu of injections whenever you need them. Okay, another alternative technique that we have to use on the maxilla. This is another palatal injection. This is the palatal anterior superior alveolar nerve block. With this technique, what we're going to do is we're going to inject into the area of the incisive papilla on the palatal side, just inside the two central incisors. We're going to inject right off the side of that incisive bump there and insert the needle just a little ways up into the incisive canal underneath that bump. This will give us pulpal anesthesia from canine to canine, both sides bilaterally. It will give us palatal anesthesia of the anterior palate and also give us buccal gingival anesthesia. So a pretty complete block of those anterior 6 teeth to do restorative work, fillings, to do veneers, to do crown preps, whatever, to do root planing, anything like that. So as I say, I'm going to come in right off the side of that incisive papilla. I don't come in right over the top of it because this tends to be rather fibrous tissue. So I come in more where the arrow is here, right off the side, angling in a little bit, and just get the needle into that canal just a little ways. And then slowly inject. I'm usually about 1/4 of a cartridge. Again, I like to use articaine, septicaine for this injection. I might drop a little bit more if it's a particularly large patient. But injecting a small amount, and again doing this very slowly. And this gives me very good anesthesia of those anterior 6 teeth. On this patient here, I was using this technique to remove this bridge that had leaking margins, and we were going to replace this bridge. So this worked quite well to get all 6 of those teeth and do the reprepping, do the impression, and get the patient temporized with great comfort. Single injection. Okay, now we come to my favorite injection, which is the complete maxillary division nerve block. With this technique, we're going to use 2 injections and 1 cartridge of anesthetic. We've got 2 different techniques that we can use. We can use a more lateral posterior superior alveolar approach, which is very similar to our posterior superior alveolar nerve block, or we can use the greater palatine approach, coming into the greater palatine canal on the palatal side in the molar region. Our aim here with either approach is that we want to get into this space here, the pterygopalatine fossa. And specifically what we're after here is to get the anesthetic up here to the maxillary division of the trigeminal nerve. It emerges out of the middle cranial fossa through the foramen rotundum and traverses across the roof of this pterygopalatine fossa, and then it passes through the inferior orbital fissure and changes its name to the infraorbital nerve. So we want to get our anesthetic in here and block the maxillary division within that pterygopalatine fossa. So with the posterior superior alveolar approach, it's just like doing your conventional posterior superior alveolar nerve block, except we're going to go twice as high, twice as deep. So we're going to go twice as high to get into the pterygopalatine fossa, and we're going to angle in at a sharper angle to go up in more medially to get into that fossa. Now that sounds simple enough, and it is simple, but it has a higher risk of getting vascular involvement, of getting a hematoma, because this opening is where all the terminal branches of the maxillary artery are diving into that pterygopalatine fossa and are going to be distributed out with the terminal branches of the maxillary division of the trigeminal nerve. And here on the right side with this dissection picture, what we're seeing right here on the far right side, this cluster of little arteries, and by the way, this is only arteries. There's no veins in this dissection. All of the veins were stripped out. What we're seeing here is the cluster of arteries that are going with the posterior superior alveolar nerve branches into the maxillary tuberosity. With this block technique, we're going to come all the way up here, and as you can see, we've got some big terminal branches of the maxillary artery. So highly vascular, high risk of hematoma. I do know people who use this technique and love it. I am a little fearful of the high risk of hematoma. So the technique I prefer is the greater palatine canal approach. And with this, yes, I am actually going to insert a needle into the greater palatine canal and up that canal and potentially all the way up into the top of that pterygopalatine fossa. I'm not exactly burying this needle, in the base of a person's skull, but it's close to that. And I know people think about that and go, ooh, that is scary. I'm not sure I want to do that. Well, let me walk you through it a little bit here. So first off, we need to find out where that greater palatine canal is. It's actually more posterior than most people realize. It's usually distal to the second molar, usually about the middle of the third molar on the palatal side, if the third molar is present. Another way of thinking about it is it's somewhere between 4 and 8 millimeters in front of the back edge of the hard palate. So you can have the patient give you an awe, see where that back edge is, and palpate in that area. Generally what I do is I palpate down along the trough between the alveolar process and the hard palate, and as you go posteriorly, you feel the tissue getting a little spongier, and just before you go on to the soft palate, you'll feel an indentation here. There is always a funnel shape to the bone. The bone funnels down into the opening of the greater palatine canal itself. So I palpate for that. I will give a little block injection. Just drop about a stopper's worth of anesthetic over the greater palatine canal there. So I put my Q-tip of topical anesthetic on. I keep that on there as a distractor, as a pressure distraction, and I then insert my needle right off the edge of that to give the greater palatine block. Once I've done that, I wait for 2-3 minutes, make sure that that area is getting numb. Then I repalpate to make sure I can feel where that foramen is. And now I'm going to come with my needle, and I use a long needle here, and I am going to I'm using my fingertip to deflect the needle towards the palate, so I'm approximating a 90-degree angle, and I insert one time and then gently probe until I feel the needle drop into that canal. Now, if I'm probing around and I can't seem to find the canal, I'll take the needle out, repalpate. Usually what I find is I went in too far forward. Usually I feel that the indentation's a little bit more posterior, so I'll insert the needle a little more posteriorly, single penetration, gently probe around. Once I feel it drop into the canal, I very slowly insert the needle up the canal, very passively. If I feel any resistance, I stop, back off, try to redirect the needle, see if I can get around that resistance. If I can't, then I just stop at that point. But usually I can get into that canal pretty well. And once I'm up in there, I will go ahead and drop my anesthetic. So the remainder of that cartridge of anesthetic, again, I'm doing this with the patient lying down, and I leave the patient lying down after I've delivered my anesthetic. So my depth of penetration is going to vary a little bit. I'd say I'm usually a good 15 millimeters, maybe more. I try to get more if I can. I'm using a long needle, and again, I'm dropping a full cartridge of anesthetic. And what I get is complete quadrant anesthesia. Maybe a little fuzzy at the midline, but I've got the pulps, all the soft tissue, everything is very, very numb here. This is great for doing a quadrant of maxillary restorative dentistry. It's also good for doing a quadrant of root planing or surgery, unless you're going to get a lot of bleeding. If you're going to get bleeding, then this block won't give you the hemostasis. So you can either do the block and then do infiltrations for hemostasis, or you could use your infiltrations for all of your anesthesia if that will give you adequate duration. But one thing about using this technique, and I've used it many times, patients are always impressed that you really do one injection and they're going, oh my goodness, I have never been so numb on my upper jaw before. They have very profound anesthesia. You can do wonderful, very comfortable dentistry with this technique. Now, there's always a but, as I mentioned before. There is a very small risk. This happens very seldom, But there is a possibility that when we get the anesthetic up into the top of the pterygopalatine fossa, we may knock out the little communicating branch coming off the zygomatic portion of the maxillary division. This communicating branch comes up to the lacrimal gland of the eye, and it can knock out lacrimation, tear function. So I always tell patients, if you feel that your eye is getting a little dry, let me know. We can either put in some eye drops, or we can just put some moist gauze over the eye, just so that the cornea doesn't become dry. They don't accidentally scratch that when they blink. So I'm just being careful about that. Okay, I want to talk just real quickly about management of hot teeth, because infected teeth is problematic for all of us. As we all know, first thing we want to do is try to give a block injection as far away from the site of infection as we can, because this way we'll get better dissociation, better anesthetic effect, and plus we don't want to make the local site any worse, cause more pain, or spread the infection. So we try to give a block. Now I put this slide in, although it's talking about mandibular techniques. The important thing about this slide is this statement down here that lots of times giving a block with a hot tooth is not going to be a complete profound anesthesia. You're going to have to use some secondary techniques to get those hot teeth really completely anesthetized. So, traditionally many of us have given periodontal ligament injections, which are pretty simple to do. I'll talk about a couple disadvantages here momentarily. Or some people have used intraosseous. Intraosseous technique's been very popular with endodontists for many years. But what we're starting to see now is going away from these techniques. But real quickly, periodontal ligament, I'm sure you've done this before. On a bicuspid or an incisor, I'll give it buccally and lingually into the periodontal ligament space. On a molar, I give it at all four corners. And what we're trying to do is to work the anesthetic out into the cancellous bone surrounding the tooth here. The duration of these PDL injections is a little bit unpredictable there. It's usually rather short duration, maybe 10 minutes or something like that. We're using a small volume of anesthetic, but the reason I've kind of shied away from these is that patients usually reported that the area was a bit sore for a while after the injection. For 2-3 days afterwards, every time they bit down on food, that was a bit sensitive there. And it's also recommended with this type of technique not to use a vasoconstrictor, because we are getting the anesthetic into a very vascular space there, and we may get a little more cardiovascular side effects. We want to be careful there. There's also a couple precautions here. We don't want to use too much force. There have been reports in the literature of causing both reversible and every once in a while irreversible damage to the bone or root resorption, some type of injury like that, or causing recession in that localized area. So you want to be careful not to use too much force with a periodontal ligament injection. With children, particularly with primary teeth or mixed dentition, I'd recommend you not do this, because you run the risk of potentially injecting into the developing permanent tooth bud underneath, and you may cause damage to that developing tooth. And then finally, with the periodontal ligament injection, because we are going through the sulcus, which almost always has some plaque in it, these patients are at risk if they have an artificial heart valve or have a history of endocarditis, anything like that. So it's recommended in this one injection that we should prophylax before we give the injection. Now, intraosseous technique, we're going through the cortical plate, and this will anesthetize the teeth on either side. This is, again, an old technique going way back, and this a number of different systems that we can use for this. One thing with intraosseous is you want to take a radiograph first, or take a good look at your radiographs. Make sure you've got space. We're going to come in between the roots. For example, here you can see that there's very little space between 18 and 19. That's not a good candidate space to give that injection. So I wouldn't want to try it there. Is there an impacted tooth that might impinge on the area? Is there a periodontal defect, some vertical bone loss there, or is there an abscess in that area? So we want to take a careful look clinically before we use this technique. We're going to give it into the attached gingiva 2 millimeters below the free gingival margin and in between teeth. And we're first going to give a little infiltration over the area so we make the perforation site comfortable. And now I'm coming in and perforating. On this patient, we've got a bit of a mucogingival defect here, so we don't have much attached gingiva to go through. But I want to feel that perforator pop through the cortical plate. Once I feel it drop through, I'm going to take that perforator out, insert my needle into the hole, making sure that it's going in and I'm not getting backflow out into the vestibule, making sure that my anesthetic is going into the bone there. This gives good, reliable success rate there. It's a little longer duration than the periodontal ligament. Gives us almost a half an hour of pulpal anesthesia. And I can always come back in through that same hole and give a second injection if I need to. Again, we're using a very small amount of anesthesia. We're getting the teeth on either side of the injection site. Nice thing here is we don't get any lip anesthesia and no postoperative discomfort at all. And again, recommended to use a non-vasoconstrictor containing anesthetic. But actually what you'll see is being done more often now, and this is reflected in the endodontic literature in particular, is that rather than using these periodontal ligament or intraosseous techniques, is that they're using buccal and lingual on the mandible or buccal and palatal infiltrations with articaine, with septicaine, and they're working very, very well as the backup to the block injection. So here, this is again talking about mandible. But this was a very nice study done by Robertson and his group and published in the Journal of the American Dental Association. What they did was a single infiltration on the buccal side of the mandibular first molar. They did it with lidocaine at one appointment. They did it with articaine at another appointment. What they found doing pulp testing is that with lidocaine, 45% of the time the pulp of the second molar was numb, and 67% of the time the pulp of the first bicuspid was numb. But when they did the same buccal infiltration with articaine, 75% of the time the second molar was anesthetized, and 92% of the time the first bicuspid was anesthetized. So quite a significant difference in the success of pulpal anesthesia, and also the articaine gave faster onset. As you can see, less than 5 minutes for the articaine, 6 to 11 minutes for the lidocaine. So both more success and a more rapid onset. So pretty tough to argue with that. And then is that lots of times when we give a buccal infiltration with articaine, we also get lingual soft tissue anesthesia, so we don't have to give a second injection to get the lingual or the palatal side with a maxilla. So that's nice. And I just want you to think for the molar area, if this is more for the mandible, but with a thin lingual plate, if we give an infiltration back here in the molar area, that's going to work very well. So I always say, you know, why not give the infiltration both on the buccal and on the lingual, or with the maxilla on the palatal side. I use a half cartridge of articaine. I give my block. I automatically will go ahead and give the infiltration with articaine on both sides of the tooth. And you know what? I don't have that much difficulty with hot teeth anymore. I won't say I never do, but certainly not as frequently. There's no contraindications to using combinations of anesthetics like these. You know, I think it is worth noting that with hot teeth, plain anesthetics theoretically would work better because of their better dissociation in the acidic environment. But the problem is that you have greater vascularity in a site of infection, and therefore these plain anesthetics will wash out faster and not give you good durability. I know a lot of people like to use plain anesthetics, particularly plain prilocaine, as a pre-injection, and that's because the plain anesthetics are not as acidic as are the vasoconstrictor-containing anesthetics, so they have a little less of a burning sensation. And there's nothing wrong with that. I just want to make you aware that if you do that, you may get a little more uptake if you chase that first injection with plain anesthetic with a little bit of vasoconstrictor. You may get a little more cardiovascular side effect because you vasodilated with a plain anesthetic, and now when you add in your vasoconstrictor, you're initially going to get a little more uptake into the bloodstream before the vasoconstrictor can act and shut down the vascularity in the local area. Okay, again, no contraindication for combining our anesthetics. The only thing you always want to keep in mind is that our anesthetic agents are additive, and so we don't want to exceed the maximum safe dosage of the agent of highest concentration. So for example, here's a little chart talking about our dosage and how we calculate it. Roughly it's about 18 milligrams of anesthetic per percent concentration. So these numbers listed here, 2% lidocaine, 2 times 18, 3 times with bupivacaine. These are not exactly what's in these cartridges, but they're close. With articaine, it's actually a little less than the 18 number, but very close. And you'll note down here at the bottom, all of our cartridges are labeled 1.7 cc's now, but this is due to a labeling law change. They actually have closer to 1.8. It's just the law says that you can't label them as 1.8 unless every cartridge has a minimum of 1.8 cc's in it. But anyway, we won't digress on that subject there. All right, so here we have our maximum dosage per pound, and you can see that all of our anesthetics do have a maximum dosage that is allowable by FDA, maximum recommended dosage. That's within a 24-hour time frame. So using those numbers, here's 2% lidocaine with epinephrine, 150 pounds patient, 3.2 milligrams per pound. We divide that by our 36 milligrams in a cartridge. We get 13 cartridges. Plenty of anesthetic for, I can't imagine a situation where I would need that much anesthetic, hopefully never. But it means I could use up to 14 cartridges for a patient of 156 pounds. That's a lot of anesthetic. But here with articaine, now notice the numbers are the same. It's still 3.2 milligrams per pound, still the same maximum 500 milligram limit, but there's twice as much, almost twice as much in a cartridge, so we can only use half as many cartridges, 7. For most dental work that I'm doing, 7 would still be a high number. But if you're going to combine these two together, say for example, you're extracting 4 wisdom teeth, or you're doing a long duration procedure and slowly adding on more anesthetic, if you're using articaine in combination with lidocaine, you have just greatly restricted the total number of cartridges you can use. Using that example of wisdom teeth, it would not be atypical to use 2 cartridges, maybe even 3 cartridges per quadrant. 2 cartridges per quadrant would put me right at 8 cartridges. Already I've exceeded my maximum dosage. So I don't really want to use articaine for that type of procedure. And here with prilocaine, yeah, I can use a little bit more, 8 cartridges, but still it's limiting my total ability to get good anesthesia in that type of procedure. So one more time, here's my armamentarium. For most blocks, I'm using lidocaine and nothing else. For most infiltrations, I'm using articaine and nothing else. But, you know, there are a few blocks, like I mentioned, those palatal anterior superior and anterior and middle superior alveolar blocks. I do like using articaine for those type situations. Okay, so I should wrap up my talking here and answer some questions. So I just want to point out that really, you know, for success is making sure the patient is completely comfortable throughout the entire duration of the invasive portion of our procedure. And that really depends on the procedure itself and very much depends on the patient. Some patients are extremely stoic and don't seem to feel anything. Other patients, you know, you gently touch them with your fingertip and they jump. So we're going to have to gauge our success based upon what's necessary for the individual there. And in terms of our techniques, our infiltrations, our blocks, which type of blocks and so forth, really depends, again, on what we need to do. How invasive are we going to be? Who's the patient? What's the patient like? What's my comfort zone in terms of giving these different techniques? Am I using the proper technique? And am I using the right anesthetic agent? And am I using it for the right technique? Again, you know, for example, prilocaine plain, given as an infiltration, very ineffective pulpal anesthesia. Given as a block, now I've got maybe 45 minutes to an hour duration. So it really makes a big difference to think about what we're doing and how we want to combine things. last off, really, it's just, again, it's something that we need to think about. Anesthesia is not just that straightforward. You load up a cartridge, inject whatever it is. You really got to think about your technique and plan it out. It's very, very much every bit as important as every other aspect of your procedure. And if you do get good quality anesthesia, that's when patients start to really trust you, start to really relax, and start to open up wide. And boy, if I can get my patients to open up wide like this, I can do really, really good dentistry. But if they won't open wide like that, it's a struggle, it's hard, we've all been there. So